Hello everyone, it is that time for that compilation video this week. With my scratchy voice, we've been talking about tubal ligations and tubal sterilizations and post-tubal ligation syndrome and all things kind of tubals there. If you wanted to know, the languages this week were Dutch from the Netherlands, Nahuatl from kind of a native Aztec language, and then Yoruba from Nigeria. So yeah, anyway. Well, kind of looking at everything together, talking about tubal sterilization, I brought this up kind of with all the new changes that have been going on with, the overturning of Roe versus Wade and some of the big questions I've been getting from people about, well, how does tubal sterilization kind of go into this and everything? So I thought it'd be a good idea to address all of those things. So basically, tubal sterilization is a form of sterilization surgery. Nowadays, it's basically done either two ways. One through little teeny poke holes on the belly, that's called a laparoscopic tubal ligation or laparoscopic tubal sterilization. And the second is done through an incision. Now that can be done either immediately following a vaginal delivery, that's called a postpartum tubal, or you can have that done at the same time of a C-section. And so that would be a tubal ligation with a C-section. The tubal ligation as a general kind of rule, the point is basically to cause a gap or an issue with the tube that inhibits the traveling of the egg through the tube and inhibits the sperm from meeting the egg and therefore keeps fertilization from occurring. Now, the uterus is connected to the tubes. There are two tubes, one on each side, and they have these little things called fimbria on the end of little fingers. And inside of the tube itself, there's kind of like a tunnel, and it has little teeny hairs called cilia. And what happens when you're walking around is that your tubes are kind of flowing in the wind like this. And when you ovulate and the ovary releases an egg, and that egg falls down into the pelvis, well, those tubes sweep down and little fimbria go by and whoop, pick it up. And then it kind of propels that egg through the tube and out the uterus, and so on and so forth. So the point of the tubal sterilization then is to inhibit that process at some form or fashion. Now, tubal sterilizations in terms of one's done either laparoscopically or at the time of C-section, there's well, actually done really any of them. There's a bunch of different subtypes. And these have names like the Parkland or the Uchida or the Pomeroy or the Kroner or whatever it may be. And they're just using different techniques to kind of cause that interruption to occur. Now, you can do what's called a salpingectomy, which is the removal of the entire tube. That's a different surgical procedure than a tubal sterilization. So for that reason, a lot of times insurances won't cover that. Now, I know some of you may be saying, well, but what about the benefit potentially for reducing the risk of ovarian cancer? And that's a very good question because we know that tubal factors do play into ovarian cancer, or for a lot of different types of ovarian cancer. But as it stands right now, unless you have a very strong family history of that or are considered high risk for that, insurance companies don't typically pay for the salpingectomy. The other thing to consider too is if you're ever thinking about maybe having that tubal sterilization reversed in the future, if you don't have a tube, you can't get that reversed. So that's something just to kind of consider. But anyway, basically, those are kind of the main types that occur nowadays. Now, even when I was in training, there were a couple of other different what are called hysteroscopic types of tubal sterilizations. Those are mainly called the Adiana and the Escher. Adiana used a little silicone ball, if you will, that was placed into the tube up through the uterus. And then you used heat basically to cause it to expand and to occlude the tube. Same with the Escher coils. Those would kind of create a little coil in the tube and it would scar it down and it would make a tubal occlusion. So a little bit of a difference there in terminology versus a ligation, which is a tying, but it's all really the same thing. You're basically inhibiting that egg from meeting the sperm. That's really what this is all about. So now, these surgeries are very, very, very successful in preventing unintended pregnancies. Basically, they're 99.995% successful. Roughly 5 out of 1,000 women will conceive following, or 5 out of 1,000 people, will conceive following a tubal sterilization surgery. And if that does occur, the vast majority of those are actually what are called ectopic pregnancies, or pregnancies that occur outside of the uterus. So yes, that can happen, but if it does happen, usually those do not go the way that we want them to. But that's always something to kind of consider. It's not 100%, effective. Likewise, like I said, you can have them reversed. Now that's a little bit of a trickier thing, and I guess that's a good segue to kind of talk about that. Tubal reversal is a procedure that's been around for a while, honestly. Originally, it was done through what's called microsurgery, which is using an operating microscope, basically to go in and you kind of look in like 40% magnification, or 40 times magnification, excuse me. And you basically, cut out the bad section of tube, so you have two good tubal sections. You put them back together, suture them up, inject some dye through the uterus and through the tube to make sure that everything stays watertight and that dye can go out the other end, and bada bing, bada boom. There you go. And this was originally created basically to avoid or to deal with, to help people who had had a tubal sterilization and wanted to get pregnant again. Well, with the advent of in vitro fertilization, that bypasses tubal issues altogether. So nowadays, there are only specialized centers or specialized practitioners that do tubal reversal surgeries. You can do them laparoscopically, with like kind of a telescopic laparoscope, to where you can really get that zoom in there. And the procedure is still pretty much the same. You're going in and you're basically attaching two good ends of tube together, as opposed to having that problem in the center. Now, I will also say there are a couple of other types of tubal ligations that use clips or bands. Those typically are easier to reverse because you're not actually obliterating a portion of the tube there, more or less. You're kind of going in and putting like a device on there to clamp it off. Now, a lot of times what will happen with those is that portion of tube that has been clamped or banded will die off, but it's smaller, and you have less collateral damage than you do if you were to go and, let's say, like burn every centimeter of tube or something like that. So those are called Filshie clips and fallope rings, respectively, the clips and the bands. So, with tubal reversal, kind of jumping back to that, insurance companies don't pay for this a lot. They may pay for IVF, or they may pay a little bit for it, but typically it's kind of an out-of-pocket expense, and that can range anywhere from, I was looking at figures last night, $5,000 to $9,000 throughout the country. You may find people that do it cheaper if you really look around, but it seems like that's kind of the average, between $5,000 and $9,000. Now, the thought with that is, obviously you do that surgery once, and you can try and conceive on your own. Obviously, with fertilization and with fertility just in general, there's a lot that goes into that. So you can't, if the issue is more than just the fact that you had a tubal sterilization procedure, well, you also have to still address all those other things too. So that's something to kind of keep in mind as well. So the big thing that always comes up when talking to patients about tubal sterilization, especially kind of here recently, is this kind of diagnosis, or this condition called post-tubal ligation syndrome, or PTLS. PTLS basically it's almost kind of like menopausal symptoms. It's the best way to think about it. Hot flashes, night sweats, mood swings, changes in sex drive, things like that, weight gain. And typically, people are reporting that they have their tubes tied, and then these symptoms begin to develop soon afterwards. Now, from a physiologic standpoint, this is kind of an interesting thing, because the tubes themselves do not secrete hormones in any significant amount. There's a little bit of follicle-stimulating hormone that's secreted by the tube, or not follicle-stimulating hormone, excuse me, amylase, that's secreted by the tube. It's, other than that, they're really not very, hormonally producing organs. And so, it's something that you kind of wonder, well, why does this occur? And so there's some theories out there. Like I said, the main one that I think makes the most sense is that if you're doing tubal sterilization, especially if you're burning or you're really taking down a lot of that tube, there is some what's called collateral circulation that occurs in the mesosalpinx. That's the tissue below the tube. And that goes to the ovary as well. So in theory, you can kind of disrupt or affect that collateral circulation. And what that does then is it causes decreased circulation to the ovary, which makes the ovary not work as well. So like I said, that's kind of, it's a theory. It hasn't been proven yet, especially with post-tubal ligation syndrome. But that's the thing that I can make the most sense of. Now, obviously, I will say if you have like a, filshy clip and you have an allergy to that clip, sure, I could see that too. But for the patients that don't have that, that's the only thing I can think of. I will say, if you look statistically, the vast number of people who are having tubal sterilization procedures done are having them done in their 30s. We do know that gonadal function declines once we hit our 30s. So it may be something that this is enough of a system shock that, it's affecting things too, just kind of in conjunction with that gonadal hormone production, change. And especially if these are done immediately postpartum, there's a huge hormonal shift there. And the older a patient is when they get pregnant and deliver, the more you may experience some of those issues too. So those are just some kind of thoughts about that. Now, a lot of people who have PTLS will say, okay, if I get my tubal reversed, then my symptoms get better. And that I don't really understand either, because once again, it's not like you're immediately, restoring blood flow to the ovaries or things like that. You can read stories about people saying, I woke up from my surgery and all of my symptoms were gone. That's great. That's wonderful. I hope that happens for you. But once again, physiologically, it doesn't really make sense. And so I always kind of wonder what's really going on here. Is there something else we're missing? Is this more of a causal relationship? What really is kind of at play? But honestly, it doesn't really matter if you feel better after the surgery and you're like, my symptoms are gone. Great. Who cares? That's really what this is all about, right? Placebo effect is still effect. It doesn't matter that it's a placebo effect. If you're feeling better, that's wonderful. So obviously, there's lots of resources out there about PTLS from more kind of patient standpoints. The medical literature is kind of not very, it's not robust. It's kind of lacking. And so from a medical standpoint, PTLS is kind of considered more of a fringe diagnosis, if you will. There's enough people who talk about it to make you say, well, okay, what's here? But there's not a lot of literature to say, okay, this is why this happens. So anyway, and then this is something, when you think about medical training or you think about especially gynecology training, we don't really get training in these things. We're all trained how to do tubal ligations. Very few gynecologists are trained, especially in residency, how to do tubal reversals. Typically that's advanced training that you would do kind of on your own or as part of like a microsurgery fellowship or a reproductive endocrinology and infertility fellowship or something along those lines. But not just your general gynecologist doing that. So anyway, that's kind of my spiel about tubal sterilizations. So if you obviously have any questions, let me know. I'm going to be off next week, but I'll be back the week after that. So otherwise, have a wonderful rest of your day, and we'll talk to you soon. Have a good one.